let me ask the question a different way to everybody, because it's the same question. So someone that you have, we've talked about the de novo patients, which may be 40%, maybe less, depending on what part of the world you're in, I think more than anything. But a typical patient in the US, for example, and maybe in Europe as well, is a woman who's been on endocrine therapy for maybe 2 years, 3 years, 4 years. She's postmenopausal. She's been on likely an aromatase inhibitor in the adjuvant setting, and now develops a pleural effusion or new bone mets. What's the right treatment? Is it fulvestrant? Is it fulvestrant and a CDK4 inhibitor? Is it an AI and a CDK4 inhibitor? These are the questions I think people want to know right now.
I can start it. I think when we speak about therapeutic algorithm, we should take into account two things. We are, in any interpretation for any clinical trial, I think the magnitude of effect is important. The magnitude, the delta is important. The side effect as well, the quality of life. Of course, the cost burden, that's from one side. And this other side, we are, okay, well, we discussed here the first line, but we should always think about second and third line and what we have in this line of therapy. So this is a package in my opinion. If we take Falcon trials, the data I saw so far, okay, there are a difference.
3 months.
3 months.
16 versus 14 or 16 versus 13.
Except in this group of patients with no visceral disease.
Which is like 22 versus 15 or something.
I am not, let's say, testing here the therapeutic algorithm, but probably we should individualize. I agree with Hope. Possibly we have all these drugs in our hand. We have fulvestrant, which is solid in first-line setting, let's say. We have the CDK4/6. The magnitude effect is really important, is huge. The difference in PFS is 10 months for one study and not yet known for the Mona Lisa 2 study. So I think individualization, whenever possible, could be the things to do, taken into account the situation of the patient, the disease, the patient characteristics, symptoms, and so on.
I think, if you have a patient relapsing while taking an AI,
yeah,
I would go with fulvestrant and a CDK4/6
exactly.
inhibitor.
But not fulvestrant alone. That's really the issue.
No, I would use the CDK4/6. I think that it's particularly important in that setting because we are really doubling the progression-free survival,
Correct.
and it's very well tolerated. For patients who've gotten an AI before, this is where I think, we really have a big question because we don't really know the right answer. They got an AI before, and then they relapse 3, 5, 6 years later.
That's a different question than relapsing on an AI.
Those patients, I've given it generally an AI and a CDK4/6 inhibitor too, although you could use fulvestrant and a CDK4/6 inhibitor.
May I ask a provoking question?
These are go ahead, be provocative. This is the idea.
What about, using in this situation everolimus with exemestane?
Right, that's a whole, but let's kind of put this in perspective. So we have the first line therapy, at least no de novo disease,
okay,
right? Say the de novo first, and it sounds like we've agreed on fulvestrant or palbo plus an AI in someone who's never been treated. And that probably could extend to the woman who's maybe had her AI but now has been off therapy for 3 or 4 years. So it's kind of the same kind of patient. We treat de novo and that kind of patient the same, even though we're not quite sure they really are the same. Before we go on to the second line, let me ask a question. Does it matter which CDK4 you would use? Because we now have the ribociclib data that just came out. Does it matter? Will it matter?
Up until today, it was a difference because I thought CDK4/6 inhibitor equalized to palbociclib. Now with the new data, ribociclib, seeing what the side effects are, it seems to me personally they are more or less overlapping, so they are very similar. Maybe we will go to abemaciclib.
Yeah, but what about it?
We have ribociclib and palbociclib, so it seems that they are very effective drugs and have more or less the same percentage of side effects. I don't know, Hope, if
Would you agree? You guys agree?
I think so, and I don't know where it's all going to fall out. We're going to have, sort of an anastrozole, letrozole sort of situation is my guess, but with one drug that has, data also with fulvestrant, so, we don't have that yet with ribociclib. So, we'll see. Palbociclib is already in the large adjuvant PALLAS trial, and, there are neoadjuvant trials going on.
Post-neoadjuvant?
Post-neoadjuvant, yeah.
The post-neoadjuvant
That's
trial.
I think, palette.
Palette.
Isn't post-neoadjuvant?
Penelope
yeah,
B.
the cooperative group trial.
Penelope B.
Oh,
is the
Penelope.
And
Penelope,
then
right.
So there's two. There's
So many
another one.
women.
But the
Women.
Penelope B, which is being run by GBG and is an international collaboration, is another post-neoadjuvant trial, which is 1 year versus 2 years for PALLAS. And then we have abemaciclib, which crosses the blood-brain barrier, where there's a brain study. There's also single-agent activity, although modest, causes diarrhea. It's more of a CDK4 rather than 6 inhibitor. And so, we'll see, because we're that data with abemaciclib is emerging. And then there's combination data from the preclinical setting, where if you combine a PI3 kinase or mTOR inhibitor with CDK4/6 or CDK4, that you can significantly enhance activity. And there's actually a study with an IV PI3 kinase inhibitor, gedatolisib, that's being given with palbo in people who've progressed on palbo, and either letrozole or fulvestrant in phase 1b. But quite intriguing, there is a randomized phase 2 trial looking at ribociclib and everolimus with exemestane compared to just the exemestane everolimus. I think it's actually fascinating right now to see what we're going to be doing with combinations, how we're going to balance the toxicity.
Right. But right now, clinically, sounds like we don't have a consensus yet on how to do them. I mean, it sounds like, everybody should get fulvestrant at some point with or without a CDK4. Someone should get an AI with or without a CDK4 in some combination in the first and second line. Yeah. We don't quite know which way.
We still have everolimus.
And then where does that put, now back to your original question,
as long as you
where
use
does
a
it put
steroid
exemestane?
mouthwash.
Where do we put exemestane and everolimus? After all of that? So after fulvestrant and AI and palbo in some combo.
I think so.
Then exemestane and everolimus is like third line?
I think if CDK4/6 move to the first line setting, in this patient, exemestane everolimus would be the next.
So you have a woman, so let's do the clinical scenario. So a woman comes in 3 years after finishing all her endocrine therapy. You give her letrozole and palbociclib,
yeah.
and it's now, 2 years later, and she progresses again. So your choices then are exemestane and everolimus or fulvestrant.
Fulvestrant.
Fulvestrant?
Taking into account the side effect, I would.
But Hope has this great mouthwash trial.
I will go to, of course, to fulvestrant. But I saw Hope study looking to reduce the mucositis problem. It's a very interesting study, honestly. It's very easy. It's 0.5 milligram dexamethasone in 5 milliliters, that's correct? Yeah. And help a lot the patient, reduce significantly the mucositis. But there are other side effects, to be honest, also.
We have pneumonitis and fatigue.
Right, pneumonitis is not something that's to work, it's something
once again, possibly individualizing the strategy of the patient with the aim that they receive the maximum of benefit from available therapy. That's my...
I think a lot of people may go to fulvestrant next because they've used an AI, and then they go to the AI again with the idea of recovering sensitivity, et cetera. And everolimus, I think most people are now in patients that are worried about starting at a lower dose, going up, having an earlier dose reduction, et cetera. So, toxicity does seem to correlate with exposure to drug, and so that's probably a way to manage it.